Good evening, everyone. Thank you so much for having us today. We're pleased to be here. As the mayor said, my name is Rich Vedder. I'm a family physician. I'm from a small town in North Dakota called Linton, and if you know where North Dakota is. I've practiced family medicine and with obstetrics in Fargo for 25 years until taking on the chief medical officer role at Essentia in Fargo about 5 years ago. I want to thank you for the opportunity for this important conversation this evening. We know how important healthcare is to any community, and we know how important high-quality healthcare is to this community. Essentia Health and the community of Fosston have a long history of working together to provide quality healthcare and wellness for this community. I hope to share some of that with you this evening. My hope is at the end of our conversation today, we will all have a greater appreciation of some of the challenges that are facing rural healthcare and in rural America, and in particular rural Minnesota. And Fosston is part of that as well. So hopefully we'll be able to share some of that information with you, and that's my goal. So I have some slides prepared we're going to walk through. So again, the key takeaways for this evening are really going to be to show you or try to outline for you that maternity care is changing, becoming much more complex. And when I started practice 30 years ago, it wasn't unusual to be able to deliver babies in small hospitals without C-section capability. And if that became a necessary intervention, they just pack them up in the ambulance and ship them. That's no longer considered standard of care. So I'll go through that a little bit. Higher patient volumes are needed to be able to sustain a safe and delivery care model. As care has become more complex and patients have become sicker, it takes a more highly trained staff to be able to do that, both nursing staff, ancillary staff, physician staff, including the ability to do C-sections on a critical need. All of those challenges are tied into making recruiting for that much more challenging. And I'll talk about some statistics around family medicine with OB, who provide the majority of care to rural communities, and some of the challenges in the numbers of people going into that. And then I'm also going to summarize a little bit about kind of the excellent care that is currently being provided within the Fosston community around prenatal services, postnatal services, baby care, and so on. Again, I want to stress that we're committed to the Fosston community, and we're committed to safe and high quality care. So in the past 5 years, Essentia has invested nearly $80,000 in critical community initiatives, and that's impacted over 4,200 individuals to the Fosston and surrounding communities. Some of those investments resulted in supporting the Prairie Pines Child Care Center, supporting resurfacing of the track and field in Fosston, helping with the new pickleball courts, development of a youth mentor program in partnership with the Boston Police Department, helping support remodeling the Community Wellness Center to provide art therapy and behavioral telehealth services. The mayor commented a little bit on the economic impact to the community of Fosston. So last year, Essentia served over 9,400 patients, employed about 258 individuals with $12.6 million in wages, and an additional $6.6 million in non-labor expenses, so for a total of about $20 million impact to the community in the year 2022. In addition, you can see the capital investments that Essentia has made to the community and to the facilities over the last 11 years of about $13.6 million. So what I would also like to try to stress tonight or get across is we really want to be here to develop a shared vision with the community about how can we better provide services to the community and the services that are needed for this community. Some of the things that we've been talking about are adding additional preventative care, preventative medicine programs, adding or supplementing some additional specialty care and some outreach opportunities, expanding some of the technology, and also looking at urgent care and emergency room expansion and improvement. We got a tour today from Callan and Dr. White, and they stressed and showed us the need and the layout of the current facilities that you have. And I would agree, it definitely would benefit from an upgrade. So the reason we're here today is to really talk about OB delivery services to the community of Fosston. So as I mentioned, the current practice standards have evolved over the last 20 to 30 years. The volumes needed to support competency training for this complex care is really important and really affects our ability to recruit. If you don't have the volume of patients, most of us that went into doing deliveries, we're always looking for about 30 to 50 or 40 to 50 deliveries per year to maintain our competencies and our skills. And so that's for each doctor. C-section availability within 20 minutes. Advances in labor and delivery care, the fetal monitoring, the training of staff, much more complex than it used to be. The ability to care for those patients that are much sicker than they were, and I'll show some data on that. Ability to manage complications, this is critical. Obstetrical services can be going along just fine, and at a moment's notice, you have an emergency, and you really don't have time. So you got to be prepared 24/7, 365 to manage those complications. Call expectations. The new providers that are coming out don't want to work 24/7, 7 days a week. The call expectations that we hear from young physicians, 1 in 4, maybe 1 in 3 if you push them, but for the most part, 1 in 4, 1 in 5 is what they're really looking for. They're not like physicians were 30 years ago where we'd be on call all the time. That's just not realistic any longer. And probably wasn't good for us either, by the way. Higher risk patients, I'm going to show you some data to show how our patients have gotten a lot sicker over the last 10 to 15 years. And then because those patients are sicker, the neonates have a more difficult time transitioning to being outside of the mother's womb, and so resuscitation is being much more frequently needed. And then including those other ancillary skills like anesthesia and OB/GYN consultative services when needed. So this slide I'm going to spend a little bit of time on because this really, I think, is important. If you look at maternal mortality, and if you've been doing any reading or following this in the paper, maternal mortality has doubled just in the 3 years from 2017 to 2020. And that's particularly true of rural communities. The last thing we want is a maternal mortality. In my 25 years of doing obstetrics, I had one, and that was in a facility the size of a Fargo's hospital. It's not good for the patient, of course. It's not good for the family. It's not good for the providers. It's not good for our staff. It's not good for anyone. When you look at some of the complications that we're seeing, pregnancy complications, diabetes, you can see this is Blue Cross Blue Shield national data, increased from 2014 to 2018. So already this is 5 years old, this data, but it went up 16%. Since that time, it's even gone up more. And many of you know, even in the non-pregnant population, the incidence of diabetes continues to rise in our communities. Preeclampsia. Preeclampsia is a condition that's particular to pregnancy. The main feature is high blood pressure, but it can affect circulation. So it can affect the circulation to the baby. Baby can have intrauterine growth retardation where it doesn't develop, right? The placenta can get damaged by that high blood pressure, so the challenges of labor and delivery are much greater, so it puts the baby at greater risk during delivery. Placental abruption, so the placenta can just separate from the uterus, causing immediate emergency for both mom and baby. And then can also lead to what's called eclampsia, which is that condition leading to a seizure, which is a life-threatening condition, again, for both mom and baby. I've seen all of these in my practice of obstetrics over the past 25 years. You've got to be prepared to deal with them. The childbirth complications, you can see there mentioned eclampsia, up 57% just in that short 5-year time frame. Cardiomyopathy, which is a dilation of the mom's heart that occurs, again, uniquely to being pregnant, called peripartum cardiomyopathy. And they go into heart failure. So they get short of breath, they retain fluid, again, can be a life-threatening condition. Embolus, they can get blood clots that can go to the lung and again be life-threatening, again, up 32% just in that 5-year time frame. So our patients, again, are much sicker than they were 20 and 30 years ago. Sepsis, which is a severe infection, basically a bloodstream infection, 45%. We've been putting a lot of effort into reducing blood transfusions to try to mitigate the risk of blood transfusions. That's why you can see the transfusion number is down, but maternal hemorrhage is still one of the top 3 causes of maternal death in the U.S. And then respiratory illnesses, almost 50% higher than they used to be, and again, just in that short time frame. So again, what I'd like to stress is that we need to have providers and staff that can recognize and treat these conditions, have to have the availability to transfer these patients to higher levels of care when needed. Because you have these higher risk individuals, a lot of them are going to get transferred to those higher levels of care before they even deliver at your hospital. And so again, I think even if you had a number of deliveries that you were doing in the past, because they're sicker, they're going to have to be delivered at higher levels of care to provide that quality of care that we want for our patients. Why are all these going up like this? I don't think we really have a good understanding of why the prevalence of could be high blood pressure, with preeclampsia, and it's gone up since 2018 and continues to go up. We don't really understand why. But again, all of these conditions are leading to that increase of that doubling of maternal mortality that I mentioned earlier that you probably read about. And again, it's higher in rural communities, and we want to make sure that if we're going to be providing care in rural communities, we provide the best care possible. So I'm going to just review a little bit of some national trends and then some local trends. So between the years of 2011 and 2019, nearly 200 rural hospitals stopped providing services because of these issues that I was mentioning. Sicker patients, decreased volumes, not enough physician staff, not enough highly trained nursing staff. The states with the biggest losses, you can see this is from a group that reported this out a couple years ago: Minnesota, Texas, Oklahoma, and Iowa. In just the first half of this year, another 20 hospitals have discontinued labor and delivery services in the U.S. because of these challenges. So if we look at more regional data, I reached out to the State Department, Minnesota Department of Health, and got this information. You can see in Minnesota the various communities that have discontinued labor and delivery services, and a couple there in North Dakota as well, and cities larger than Fosston and with deliveries higher than Fosston. I was visiting with one of our providers or one of our physicians in Jamestown recently. They do 300 deliveries a year. They're having difficulty finding RNs that have the skill set to be able to help deliver babies. So they want to birth, or at risk of going on to birth because they don't have enough trained staff. So again, even larger facilities are challenged with some of these. So this is a study that was reported in JAMA about a year ago, which is the Journal of American Medical Association. They did an interview of hospital leaders looking at what is the minimum number of patients that they felt were needed to deliver safely. 34 of these were critical access hospitals. Again, Fosston is a critical access hospital. 65% were located in rural communities, and 52% of them had experienced decline in births. And again, the number that these respondents said was around 200 would be required to provide safe labor and delivery services. If you look over the past 5 years in Fosston, from 2017 to 2021, an average of 72 births per year. I think the high mark was in 2016. I think they had 100 that year. So. The other thing that we looked at was what are the Fosston market demographics? And this was taken from the state database. And this is expectations or predictions that over the next 5 years, females ages 15 to 44 would decline in your market area by 4.9%. So again, less moms are available to have children. Physician staffing, we talked a little bit about this earlier. So this past year, 4,530 medical students went into family medicine. That's about 12% of medical students. Only 7% of family practice doctors practice OB. When I came out 30 years ago, Dr. Swanson as well, about 40% of us were doing obstetrics. Now it's down to 7%. So the workforce to do deliveries is just not there like it used to be. And then to make it even matters a little bit worse, there's only about 1.6% that are actually trained to have the availability to do C-section. We're lucky at Essentia Health, we're actually promoting or supporting a program in Duluth to train family med residents to go to an additional year of training to be able to provide C-section capabilities. We train, I think it's 2 per year, been doing that for the last 9 years. A couple of those have actually interviewed in Fosston, but have gone to larger communities where they have higher OB volumes. So that's a challenge we see as well. These people are coming out, they have a skill set that's pretty rare, and they have a lot of opportunity. Recruiting. We've been trying to recruit Fosston. This just reviews the last few years from 2018 to 2023. We've had 29 candidates that we've identified, 13 that have interviewed, and again, we've actually, this past year, we went out and got a separate search firm that specializes in rural recruiting. And so we, in addition to our own internal recruiting, we have a search firm helping us with recruiting and finding and identifying candidates as well. So we've interviewed 13 over the past 5 years. But again, like I said, a lot of them have a lot of opportunities in other communities. Nursing staff is another challenge. If you look at the number of nurses needed in the U.S., over 203,000 are being predicted. In Minnesota last year, there was over 5,600 vacancies in the state of Minnesota. Nurses are also not working full-time. You can see the number of full-time nurses declined from 52% to 43%. More nurses are going into nurse practitioner training. They're going to CRNA training. They're going into other areas of nursing that they have opportunities in. And then to maintain those skills, if you have a community that doesn't have the volume necessary to maintain it on their own, you have to take those nurses and ask them to go to a city somewhere else to maintain those competencies. And that's another burden that nurses, some may want to do it, others would just say, no, I don't want to have to do the extra travel.
Hello.
So I just want to comment a little bit about OB services. When we talk about OB services, it's really a continuum of care. It really starts pre-conception, even before people are pregnant, but they're thinking about being pregnant. The importance of folic acid, the importance of looking at the medications they're on that might be harmful to their pregnancy and making sure their medications are right, giving them the appropriate counseling, talking about smoking cessation, talking about alcohol use, talking about all those things that can affect their health and the health of their babies. In Fosston right now, we continue to provide preconception care, prenatal care, as well as postnatal care, so the care after delivery. The challenge really, as I said, is that complex resources and expertise that's really needed for that delivery component. The other thing that we're seeing more of that is kind of a hard subject to talk about is drug use. Almost every day in our Detroit Lakes Hospital, there's a mom that tests positive for drugs during her pregnancy. In our Fargo Hospital, every day there's a mom that tests positive for drug use. That not only affects the mother, of course, but affects their baby. Babies go through withdrawal, they need a higher level of care after delivery. So it's just a real problem that I know many of you are aware of that we're challenged with the fentanyl crisis and drug and alcohol abuse. And so we've been putting extra resources and effort into how to help some of those patients be able to treat their addiction with substance use programs. But we need to do more. I just want to introduce the topic of a shared maternity care model. This is what more and more organizations are moving towards, including Essentia. We have Clinics in Valley City, their hospital there no longer provides the ability to do delivery services, but we provide the prenatal care, postnatal care, the newborn care, and again, the benefit to that is the mom does not have to travel to Fargo, in that example, for all of their prenatal visits. They get the majority of that care in Valley City. They get their ultrasound in Valley City. They can get OB consultative services for those high-risk needs in Valley City, and then have the delivery in Fargo. In Park Rapids, they're doing that. Even within Fargo-Moorhead, we have physicians and providers that provide prenatal care for their patients and then delivery services through the hospital. The benefits, really it improves that continuity. Patients actually like it. As long as they know that that communication is occurring between their providers, they're actually very accepting of a shared maternity care model, because they understand that their doctor cannot be available 24/7, 365. That's just not realistic. And the outcomes are better under that model as well. Because you really have two doctors caring for you at the same time. You actually have two people that are overlooking that care and identifying where that care might, a gap might be occurring, and it can be improved upon. Just briefly, some of the things we've been looking at for the Fosston community, specifically this past year. You may or may not know that with COVID, all hospitals throughout the U.S. were challenged with staffing, particularly nursing staffing, and Fosston was no different. We had a significant staffing crisis in our hospital. We had to limit the number of medical patients we could care for. We had to bring traveling agency nurses in to help provide that care. And again, this is no different than any other hospital, including Detroit Lakes, including Fargo, including any other hospital you can name in Minnesota. We had some leadership changes. We hired a permanent director of nursing. To say she's been doing a great job, Stephanie. We had some internal stakeholder meetings. We developed a task force that you're going to hear a little bit more from later. We did a gap analysis. We visited some other locations that have low volume delivery, just to see what they're doing to improve or be able to provide that care. And then, like I said, we implemented the shared care model so that those patients could continue to receive care in Fosston, but also receive their delivery care elsewhere. So a summary of that gap analysis was really that the biggest issue we have, I would say, is adequate volumes to maintain safety and competency. Second, and right behind that, is to have providers, an adequate number of provider staff that have the competent skill set to provide that care. So right now, we need, at a minimum, would be at least 2 additional family medicine doctors that do obstetrics, and at least 1 that would provide or have the availability of C-section, so that you have 2, a minimum of 2 then, and that still would be onerous to cover 24/7, 365. And then some additional RNs that have the competency and training. And then to maintain those competencies, those individuals, those nurses would have to travel to the Detroit Lakes or to Fargo. So then that FTE is actually taken out of your community and is being trained somewhere else and then come back. So it really almost creates where you have to have 2 people, one that's off doing training and one that's here providing the care that the community needs. So I'm going to end where I started and really just kind of touch on the high points. And again, I hope that the information I shared kind of helped you understand this, that maternity care is changing. It's becoming more complex. Patients are sicker. They need a higher expertise of care many times. The patient volumes that are needed for safe, sustainable, high-quality care has to be at a minimum 200 patients per year. Recruiting challenges, we find that when we have doctors coming in and looking, one of the questions they always ask, no matter what community, how many deliveries can I be expected to do? How often will I be on call? Those are all questions that I think are very important to not just the doctor, but to their family. I talked a little bit about the shared maternity care model and how that, I think, is one option or one way that we've been able to continue to provide those services over the past year. And again, I want to emphasize we're committed to the Fosston community and we're committed to providing the best high-quality care we can for this community. So I will pause with that, Mayor, and you have a moment of silence.